Hey y'all, this is Lisa Fujioka from The House Call, a podcast where everyday people talk to doctors and various experts to break down important health conversations into plain English. In today's episode of the Diet Sucks series, I am joined again by esteemed Dr. David Kim, OBGYN at Cedar Sinai with over 25 years experience and also a former clinical associate professor at UCLA. Hey, David.
Hi, Lisa. Thanks for having me. Wonderful to be here.
Today is a topic in our Diet Sucks series that is so near and dear to my heart and many people that I know in my personal circle of women. It's how being overweight or obese is actually strongly connected to infertility. It took my husband and I 11 months of trying to get pregnant. And I went through a number of things of tracking ovulation and things like that. And it wasn't until I went to go see actually an acupuncturist who really encouraged things like don't eat red meat, don't eat lamb, don't eat beef, don't eat carbs, eat a lot of things like avocado, Persian cucumbers. And as a result of that, I think he was trying to manage my inflammation, but I actually ended up losing about 7 pounds or so. And it was 30 days with him, I got pregnant. It was just phenomenal. So I know there's a lot of things that I don't understand and I didn't even question. I was just so happy that it worked. But you, in a prior conversation with you, you really opened my eyes to the way that weight is such a contributing factor to fertility and a healthy egg and carrying that pregnancy to full term. So something you deal with day in and day out. Can you talk about what you've experienced and what you talk to your patients about when you suspect that their weight or obesity may be a contributing factor to infertility for them?
Yeah, and I think it's not always easy to tell because fertility is such a complicated process. And of course, the women's contribution to sort of the reduced fecundity, which is reduced fertility, is only about 40%. The other 40% comes from the male partner. There you have to look at both couples in totality. But when I think that weight might be contributing to it, that's something I have a conversation about. Obviously, trying to change the diet, having some caloric restriction. I usually recommend a Mediterranean diet, and it's pretty complicated as to how weight contributes to subfertility because there's plenty of women who get pregnant and they are overweight or they might even be obese. 60% of the US population is overweight or obese. But when people are having trouble getting pregnant, sometimes that even just a little bit of weight loss and a few pounds can make the difference.
Yeah, I had read that 1 in 5 women between the ages of 15 and 49 can't get pregnant in their first active year of
Mhm,
trying. And 1 in 4 women, they don't carry the
mhm,
pregnancy to full term. So, and it's on the rise.
mhm,
Um, and so, what is the number
mhm,
one sort of
mhm.
thing that you're seeing? If you talk generally, statistically, like what is some of the things that you are seeing
Mhm.
as to the reasons for infertility or not carrying a healthy full term?
Well, older age is the most common just because everyone is older now when they get married, when they decide to start a family.
Mhm.
So that's the big difference. And then as you get older, you just sometimes will have more medical problems. And as you get older, you have more weight gain. Over time, you lose muscle mass. You have more insulin resistance as you increase your percent body fat, and then that can also cause inflammatory conditions in the body. We don't exactly know how all this works to help reduce someone's fertility, but we know that it can affect things like ovulation, so that women don't ovulate as regularly. So as women gain weight, they might find their periods are getting shorter or longer or heavier, and sometimes that's a sign that there's something happening with their ovulatory cycles. There's other inflammatory conditions that are happening within the uterus itself, but we don't have a good way of measuring that. There was a period of time when some of the fertility doctors would do biopsies of the uterus quite frequently to kind of get an assessment, and there are some people trying to research the actual receptors that are showing up. But I would say it's not mainstream, so it's not something that we routinely do. Um, Also, there's people that are more overweight or obese are more likely to have an underlying diabetes or pre-diabetes, and they may not even be aware of it, especially if you're not seeing a doctor. Someone's just trying to get pregnant on their own. for several months, they may not have been tested for diabetes. So diabetes is known to increase risk of miscarriage, does affect your
Mhm.
ability to get pregnant, and then also people don't really realize this. Increases your risk of having baby with congenital anomalies, especially like heart defects, um, neural tube defects, which is the incomplete closure of the spinal cord. So it's almost twice as high. And that also seems to be the
Wow.
case when someone's obese. Overweight, it's questionable if you have increased risk of congenital anomalies, but certainly if you're obese, that's pretty well known. So it usually increases your risk by twice the amount.
Wow. Wow. I had
Hmm.
no idea it was twice the amount. That is alarming.
Hmm.
Um, and PCOS, polycystic ovarian syndrome, I've read and
Hmm.
know personally that that is
Hmm.
a almost maybe is it the number one contributor to infertility as well? And there's also a connection between PCOS and obesity.
Hmm. Well, it's hard to say if it's the number one connection, partly because it depends on the definition that you use for PCOS. So there's sort of a general definition which seems to encompass a lot of women PCOS, but there's a more strict definition, which is what I use, that probably it's not as many. But certainly there's a lot of women out there that have PCOS and they may not know they have PCOS, and that affects your ovulation. So when you have PCOS, you don't ovulate as regularly. You do gain weight. You're more likely to get diabetes over time and high blood pressure. And what PCOS is this imbalance in hormones. We all have male and female hormones, but in women with PCOS, they have a higher rate of male hormones, and there's different types of male hormones. The most prominent being testosterone. And when you have elevated testosterone, you can get sort of abnormal hair growth, hair loss. Your periods can become irregular. It can actually increase your risk of uterine cancer also. But there's something about that even if you don't have any of those signs or symptoms, somehow that increased testosterone that's occurring, and we don't know exactly why this happens, no one knows the cause, affects the lining of the uterus, that it's just not behaving the way it should. So it's more than just the ovulation issue. It's also the uterus itself is not sort of as ready to take on a pregnancy. Fortunately, there's a lot of treatments for it. For people that are having trouble ovulating, there's ovulation medication. The most effective one is, I shouldn't say the most effective, but the most effective oral medication is letrozole, which improves ovulation and have been well studied in PCOS patients.
And you have talked to me a little bit
Hmm.
in the past about for some patients, again, like you said, there's a
Hmm.
multitude of different factors that you look at, but for some, you have actually
Hmm.
recommended
Hmm.
weight management in order to help their journey, and they would be
Right,
surprised. They would react like,
right.
"No one's ever mentioned weight management." What are you seeing in those types of patients where you think the weight management would be beneficial?
Well, I think especially in the case of patients that have PCOS, because it's a little bit different. When you have PCOS, just reducing some calories and exercising, it doesn't always result in weight loss because there's just sort of hormonal factors and increased insulin resistance that you're sort of fighting against. So in those patients, especially, I recommend first is managing their PCOS, trying to get their testosterone levels normalized or their male hormones because other male hormones that increase in PCOS. And then I usually put them on what we talked about previously, a GLP agonist for weight loss. And these drugs, like I've said before, are magical. And I rarely use that word, but they're pretty magical drugs. And the combination of managing the hormones, reducing it, whether it's with birth control pills or spironolactone, and then adding in the GLP agonists such as Saxenda or Wegovy, I think those together is synergistic. So you have a lot of weight loss, you reduce the insulin resistance, you start improving ovulation. And so it's really nice actually when a patient comes to me 6 months ahead of time and says, I'm planning to get pregnant in 6 months or a year. So what can I do? And I would say up until, several years ago, we just had the PCOS management portion, but now we have the weight loss management, and it's very effective. The average weight loss for some of these medications is 20 to 35 pounds, and that's average. So some people go even higher. You do have to wash out the meds, meaning stop the meds and wait about 2 months before you try to get pregnant, only because it hasn't been studied in pregnancy, and we don't want you losing weight while you're trying to get pregnant. We kind of want you to be at an optimal weight to get going.
I was going to ask you that, which is, how far apart do
Hmm.
those two processes have to be? So about 2 months, and then you feel comfortable
Hmm.
that, okay, okay, that's good. And for
Hmm.
those who have not listened to that prior podcast, can you just give us a little bit of like what GLP is actually
Hmm.
doing in your body? You mentioned that it's based on a natural occurring hormone, and what is that hormone doing to aid weight
Right.
loss?
Sure. So GLP is called glucagon-like protein 1, and what that does is that's involved in sort of setting the appetite set point and hunger. So it kind of acts on your brain, maybe on your gut too. We don't know for sure, but there is a whole network of communications. We don't really think of it this way, but there's this whole network of communications going on with the brain, the gut, the adipose, the fat cells, trying to regulate your body to find the optimal weight and set point. And if you try to deviate too much from that, the combination of GLP, ghrelin, leptin, and all these other hormones that I think people are not so familiar with, but they're really involved in this tug of war between parts of the brain, the gut, the fat, of trying to establish how much we're going to eat to keep the body at a stable like homeostasis. And so, what the GLP does is, as you get these, it's a pen injection. Wegovy's once a week, Saxenda's daily. If you're wondering why anyone want to inject themselves daily, well, right now there's a shortage of Wegovy around the world. It was just approved by the FDA this past year, and they're just out. So they're probably out till 2023. So I use Saxenda right now. It works really well, and with just some minimal side effects of mild nausea and constipation. And what it does is, with the GLP levels being increased, as you gain more weight, the appetite set point gets higher and higher and higher. And as that happens, insulin goes higher, higher, higher. And then the insulin deposits more fat around your body. And then that inflammatory condition kind of makes everything go haywire. So what the GLP agonist medications do, it kind of resets that to like a normal appetite set point. And there's actually a lot involved in appetite. It's not just simply, I'm hungry, I want to eat. There's a whole hedonistic, emotional component to it that everyone knows. When you have a craving, it's more than just simply, I'm hungry. There can be a craving for certain things, especially sweets and fatty foods. There's a sustenance part of it that's just about, oh, I need to just eat to have enough calories to maintain myself. And then there's other emotional, psychological things tied to appetite. And it's very interesting to see all this because, anyway, the medication will reset that appetite, and people will kind of notice that some of those other aspects of the hedonistic enjoyment, the high you get from eating, gets kind of very dulled. But it does an amazing job of helping people lose weight. So that's what the medications do, and it is meant to be lifelong. But the medication, but I kind of use it just in the first 3 months to jumpstart people with their lifestyle changes, and then find a right titration, eventually a balance of the medication to improving their lifestyle.
That is awesome. I wish that my OBGYN, 5, 6 years ago would have talked to me about all of this and even just brought it up to have me
Hmm.
consider, is that something that would have helped
Hmm.
me or could
Hmm.
help me? And I just think it's awesome that you go that
Hmm.
far, into not just like what's going on
Hmm.
with, with pregnancy and fertility, but like what could be the causes and even prescribe things like the GLP-1. That's really amazing. Um, I think it's a really cool opportunity to kind of shift gears as we're talking about the GLP and we're talking about weight loss as
Hmm.
postpartum weight loss. Like that's a whole
Hmm.
other afterbirth
Hmm.
experience that women go through and
Hmm.
is
Right.
stressful
Right.
emotionally and physically, no
Hmm.
doubt. And so I gained
Hmm.
50 pounds during my pregnancy. I was one of those women where in her first term was nauseous and felt morning sickness. But the only time that I felt at ease was when I was eating. It's terrible. And the only thing that I
Hmm.
wanted to eat were carbs. I needed that bland rice or bread, and then I would feel okay for about an hour or so. So I gained
Hmm.
weight very fast. And everyone would
Hmm.
say everyone's
Hmm.
different, but you're going to lose most of it as you're nursing and, after you give birth
Hmm.
and give yourself some
Hmm.
time. I mean, I still have 20 of those 50 pounds that 4 years later I have not shed. So, do you get a lot of questions from women, whether it's before they get pregnant or when they're pregnant, who are concerned about the weight loss?
Yeah, I do get questions, but not as many as you would think, because I think after women deliver, it's crazy hard after you have a baby, and it's just chaos for the first 4 months and maybe even longer. So to some degree, there's such a focus on the baby and surviving that's kind of put off for a while. I would say it's like a year later or 6 months later, then all of a sudden the women are saying, wait a minute, like, okay, now I can catch my breath and
Hmm.
what's going on with my weight? you know, but at the time, even when you come back at 6 weeks for your postpartum visit, people might have only lost half of the weight that they're going to lose, after they deliver. The next half occurs over the next 6 months to a year. And then, as you know, I mean, as most moms know, trying to exercise after you have a newborn is just not, it's not that realistic for a lot of women. Even if you can find the time somehow because you're able to have enough support, you're exhausted. And, especially if you're breastfeeding, you're just not comfortable to be out there, be doing CrossFit or something like that. It's just not that realistic.
Right.
So yeah, it is brought up. It is true that when you're breastfeeding, you use up a lot of calories. So there are some women that, that are exclusively breastfeeding that might be helpful enough to help them lose a lot of the weight. But it's tough because there's a lot of hormone changes that happen in pregnancy, a lot of hormone changes happening after pregnancy, and while we say that at 6 weeks, you come in for follow up, okay, you're all done with us. Congratulations, you've graduated from us. The reality is that the next 6 months to a year, your body's still trying to adjust
Mm.
to hormone changes from being a new mother. So now the GLP agonist we talked about, it's not something you want to use if you're breastfeeding, mostly because there's just not data on it. And secondly, we don't want to have a situation where you're losing to like weight, while you're breastfeeding, in the sense that, if you're losing too much weight, we're not sure what to do with that. We certainly don't want the baby to get the medication. In theory, they possibly could a small amount, and then we don't want the baby to feel like, okay, I don't want to eat anymore. So that's the
Mm.
reason why we always say, if you're breastfeeding, you can't be on it. So I wouldn't put people on it until they've kind of been done with their breastfeeding. Something I've been, also reading and learning about. I know it's deviating from sort of the more hardcore science, but I've really thought about this a lot when I've been reading a lot about it for a long time, but I've read some more recent books that was very interesting. We are creatures, our brains are, hundreds to millions of years old, and they've been built a certain way, and they're built to like have regional reflexes, that portions of certain stimuli that come in, parts of your brain, gut, and everything, they're going to react a certain way because that's the way we've been built. And to separate yourself from that, you have to not automatically react. So like you were saying, to have carbs, maybe comfort eating, emotional eating, that's something that becomes a reflex. And while the medications can help, there's also another component that we can do of mindfulness where we interject ourselves. And if you can distance yourself from that part of your brain, the amygdala, that's saying, ah, go do this, get that candy bar, get that, and just give it a little bit of space before you react, it's very interesting. That space that's created allows you to be able to behave in a way that's a vote for how you want to be. And
Mm.
some of that simply can be, interestingly, just naming that hunger, describing it, describing the craving, and then also just simply saying, giving it a name, a person. It's a separate person, knowing that person has a certain interest, which is they want to make sure you have enough nutrition. But then saying, okay, I hear you, and I'm gonna let you sit there for a little bit, and then sort of in a purposeful way make an action or behavior. And I kind of tell some of my patients this even though they're getting the medication, because even though the medications don't make you, well, you won't feel hungry when you're on it, meaning your appetite will just, you just don't have much of an appetite. There's still people who say, well, I'm still going to eat because there's another component to all this, to eating. So I think the more you can separate it, and interestingly enough, they found as a separate note that like ghrelin, that's like increases the appetite, the hormone increases appetite. If you wait an hour after you eat, um, or even if you don't eat, if you just wait an hour, it kind of goes down. And I think we've all had that experience that if we just kind of waited because we're too busy or something else, all of a sudden our appetite decreased. So there's
Right.
something about parts of your brain that are saying, do this now, do this now, do this now, but it can't keep it up. And if you give it a little bit of space, and you just kind of, the more you're conscious about it and describe it and aware of it, somehow that can kind of go away. And then if you have the additional help with exercise and GLP agonists, you can accomplish so much with that. And so I just wanted to throw it in there. It's not something that we talk about very much as doctors, but it's something I've just always been interested and very aware of. And that can be applied to almost everything. And there's like more functional MRI data to show evidence for all these types of interventions.
That's fascinating. I've always just had to stay busy to kind of stay away from cravings, but I like the idea of what you're saying of
Mhm.
kind of just acknowledging it, identifying it, naming it, even giving it a moment, and that might very well just help me have more control over it, right? So I love that.
Yeah, so what you're describing is a technique,
Mm,
yeah, what you're describing is a technique of dissociation. You're disassociating
mm,
with it, distracting yourself from it. And I think that works for some people. Um, but in actuality, if you process it, it's probably more effective. And there's the reason why describing it in detail, giving it a name, giving it a person, like making it a person that's trying to push you a certain way, um, that activates your prefrontal cortex. And they found that when you activate your prefrontal cortex, which is the conscious decision to organize, name, do things like that, that starts inhibiting the amygdala. So that's why if you can do that and you give it a name, I'm going to say Sally. No offense to any Sallys out there. If I say Sally, Sally wants me to, you know, get that, mocha from Starbucks and get the chips and do all that. And you can acknowledge that, she's doing that because she's worried that I'm working too much and I'm not eating enough. But she doesn't realize I'm okay. I've got good enough nutrition. And you just kind of give it before you react to getting that mocha, before you react to buying the chips. Just giving it a little bit more space allows you to walk away from it. And this, I think, is especially helpful to try for people who don't want to be on medications, who want to try on their own to make dietary changes and exercise and everything else.
That's a great tip. I'm going to try that, definitely. I'm going to try and make that the antagonist in my life,
It
the
works
one
for
who's
it works
causing the
for
cravings.
pain quite a bit too. It works
Oh,
for pain very well
fascinating.
also. Yeah, yeah,
Fascinating.
yeah,
Yeah, you did mention it works for a whole
mhm,
host of things. I'm going to try it for cravings for sure
yeah.
because I am so weak to my sweet tooth.
Mhm,
Um, I want to talk about one other thing as it pertains to weight in pregnancy. So, CDC says a healthy amount of weight to gain during pregnancy is about 25 to 35 pounds. Um, what do you talk
mhm,
to patients about when you see them gaining a lot of weight beyond that? Like, for example, my doctor never mentioned anything to me, even though I told you I gained up to 50 pounds. And I thank goodness I didn't suffer from things like gestational diabetes, despite the weight gain and despite the carb intake.
mhm, mhm,
But when you do see someone like myself who's gaining double the amount that's recommended, unless you see something like a
mhm,
GD, do
mhm.
you even bring it up? Is it a part of healthy pregnancy that you as a doctor, consciously look at and talk
Yeah.
about?
Well, I do because we weigh all our patients that come in for each of the prenatal visits. Although there are some patients, understandably, they don't want to be weighed, and so then I can't track it.
Um,
And then, in our electronic health record software, there's a graph that graphs it out. And while you talked about that 25 to 35 pound weight gain, that's a real general for the sort of general population. If you're already obese or overweight when you become pregnant, actually that number should be much lower. It can be anywhere from 5 to
mm,
15 pound weight gain, which is not something that most people think about. So when they read the 25, 35 pounds and they're overweight or obese, they think, oh, I can gain that much weight. But actually, that is meant for sort of normal weight pre-pregnancy. And there's particular nomograms that have been looked at to know based on your pre-pregnancy weight what your weight gain should be. So I do review that with my patients, especially around the late second and early third trimester. Mostly the reason for worrying about that, and it's not easy to bring up some of these issues because obviously it's sensitive to a lot of women. So while I bring it up, there's also women who really don't like me bringing it up, and I understand that. But I'm only doing it not from a judgmental point of view; it's a health point of view. So one of the
Right.
first things I first want to take a look at is the woman's pre-pregnancy weight, because as I said before, when you're not when you're overweight necessarily, but when you're obese, the risk of miscarriage, fetal anomalies, actually no one talks about this too much, but stillbirth increases. And so much so that if you're in what we call class 2 or class 3 diabetes, ACOG, which is the American College of Obstetrics and Gynecology, actually recommends monitoring, doing fetal monitoring earlier on in pregnancy, which is like 30 minutes of monitoring the baby's heartbeat, ultrasound, check the fluid from 36 weeks or even earlier on, and then delivering, before their due date. And so that's how much of a concern we have about it.
Why is it? What is it about the obese woman that is it the weight on the fetus? Is it the blood sugar? Is it the insulin? What is exactly is
Mhm.
it that they get concerned about?
No one knows. No one knows exactly,
Got it.
but certainly if you have undiagnosed diabetes, diabetes itself is an independent risk factor. But even if you've controlled for diabetes, meaning you took the diabetic patients out of the population, there's still an increased risk of stillbirth that occurs. There's an increased risk of other obstetric complications like preeclampsia, and that's where your blood pressure goes high. You can have seizures that can affect the baby's growth. So all these things can take effect, but no one knows exactly why these things, happen. We just know that they do. Um, and then, of course, the most obvious one that we all know of is that the baby can get too big sometimes. And if the baby gets too big, then that is more likely to have a dysfunctional labor, more likely to need a C-section. So it's delicate because you don't want to so someone who might find it upsetting to bring up weight, it's a little bit delicate, but I still think it's something that we need to do for their health. And I'm not really aggressive about you have to lose this weight, you have to lose this weight, because especially if you're not obese before you come into pregnancy, you don't have the same risks, just the risk of the baby getting too big. And if the ultrasound shows that the baby's not getting too big, I'm not as, I don't really stress as much. But I just do the obvious, just cutting out sugars, cutting out, if you have carbs, changing from brown to white. So brown rice to white rice, brown bread, wheat bread to white bread, cutting the carbs in half, um, trying to do some sort of activity 30 minutes a day, getting your heart rate up to 120. And that's a good starting point. But, even if, some women just gain more weight in pregnancy, and that's not, that's okay. So I don't try to make it like, you're hurting your baby. It's nothing like that. It's just if we can kind of bend that weight curve a little bit, it'll just be more helpful. And then, of course, easier after you deliver to try to get the weight off. But if they don't have diabetes, the pregnancy's been good, the baby's weighing okay, and people, women have gained more weight than we expect, that's okay. Like that's not going to be something I'm overly worried about. But of course, after we deliver, if she wants to lose that weight, it's going to be a little more work. That's it.
And you talked a little bit about before for 6 months up to a year, the hormonal changes in the body, especially for nursing, they persist, they continue. Does having a baby, can it actually permanently change one's hormones or metabolism?
It probably does. We just don't know exactly how. There's a lot of things that change. So a lot of women will come to me after they've delivered and say, I have this cramping feeling, I have this pain, I have my periods are now, 26 days of 28, or they're now irregular. So there's something happening. It's hard to tell for sure because also your life has changed. You have a newborn and to take care of. It's growing up. You're not getting as much sleep. You're not eating as well. You're not sleeping. So there's a lot of factors involved, but probably there's some significant impact that pregnancy has on a woman's body forever from that point on. Yeah.
And if there are women who come to you about the stress, like you said, they've got some kind of, more of a routine in their life, their baby's at a stage where they are able to start thinking about their health again, meaning, what the healthy weight is
Hmm.
specifically. Are there certain things that you like to recommend first, beyond just like watching what they eat and making sure they're moving? Is there even like a certain expectation in a healthy weight loss per month that they should strive for in order to keep it sustained? Like, what do you talk to them about?
So the one thing I remind people of is, if you have a great deal of rapid weight loss, because let's say you're fasting or you're going, you're taking 1,000 calories a day or something like that, you have to remember that our brains are made to maintain our current weight set point wherever you're at. Just the hormones have all adjusted to keep it there. So when you now all of a sudden start to lose weight, you might lose the weight, but then those hormones are going to come raging back to try to rein everything in so that you're going to eat more. That's just how we are. That's how our brains are built. So I think if you were going to do it with lifestyle changes, you'd want to lose half a pound to a pound a week with the lifestyle changes, with exercise and reducing or changing what you're eating. Now, if you have to, if someone's really overweight or obese or have other medical conditions like diabetes, high blood pressure, and it's making a big difference on their health, the increased weight, I think it makes a world of difference to be on the GLP agonist, because you don't have those hormones raging back to try to make you gain weight, and you're not suffering during that process. So it's a lot easier to work out, and if you're not starving, feeling like you're starving. And you just have to remember, when you reduce your calorie intake, if you're not on the the agonist medications, and you're working out a lot, that's great. You'll lose a lot of weight. But remember that you're using a lot of calories from working out. So your brain again is thinking, I need to get those calories back somehow. So that's why, in these long-term studies, very few percentage of people can keep the weight off. I think it's under 3% of the people and these are people who usually in studies were part of coaching programs, nurses calling them all the time, them reporting, their weights and how much they're eating, and it's like 3%, sustained. And that's why I think the FDA, for their weight loss for medications, I think they're only looking for a 5% weight loss. So to them, that's like a huge success. What with the GLP agonists, you're looking at 10 to 15% weight loss, which is
Amazing.
incredible. Yeah.
Are you seeing things that are anything that you could do while you're on this postpartum weight loss journey, or even if you're using the GLP, that you would recommend is like counterproductive? Anything that you should absolutely stay away from doing, whether it's foods, exercise regimens, diets? Are there anything like that that people should be aware of?
I can't think of anything that you should stay away from doing, but something you want to keep in mind is when you don't feel like eating, you also don't drink very much. And that's where you see from some of the studies there's increased rate of um, kidney stones, pancreatitis, sometimes a little bit. And so you just want to still drink water and stay hydrated. And that's mostly what I would say. If you're just sort of overweight, you're not really obese, and you're on some of the meds, you might actually have to worry about losing too much weight. And so that's just something you'd want to keep an eye on also.
Fascinating, though. It's so fascinating. This whole new
Hmm.
era, I think, that the GLP introduces of a weight loss um,
Hmm.
evolution. I mean, it's just a whole other path for some people who've struggled for so long, that I'm really excited to see where this
Hmm.
new
Hmm.
stage goes.
Hmm.
Well, thank you
Hmm.
again, Dr. David Kim, OBGYN
Hmm.
at Cedar
Great.
Sinai. This has been a very eye-opening experience, and discussion for myself, relating it back, because a lot of women, they go through this journey and they get the directives from their physicians, but there's not a lot of um,
Hmm.
understandable bite-sized education. Maybe it's because they're just worried about so many different things.
Sure.
So to kind of step back from it years past the experience for me and really kind of sit down and focus on it, I think it's so educational. I hope women everywhere are able to take something, whether they're, before trying to get pregnant or even post, from this discussion. So thank you again. Thanks for tuning in to The House Call. Make sure to like and subscribe so you don't miss out on our weekly episodes. And if there's an important health topic you want to hear more about, let us know in the comments and we'll make The House Call. Till then, take care.